And after the anatomy, we will see individual cancers and how to image and what are the intricate findings which we must mention in the report, which will help the surgeon or the clinician plan adequate management. So moving forward, the first question we must ask ourselves is which imaging and why? It is a very important question that before asking for an imaging, what are you going to image and what is the best or the appropriate imaging technology. So let's say you're dealing with a tongue cancer and you have predominant soft tissue which is muscular. Can I request people to mute themselves? Thank you. Yeah. So it's very important to understand that if you're dealing with soft tissue structures, you need MR imaging. And if you are more inclined towards understanding of the bone, that is the mandible cortex, then you need CT imaging. So predominantly for buccal CA, people who are chewing gutka, they have retromolar trigon malignancies or they have buccal malignancies. The chances of mandible getting involved is upwards of 65%. And in such situations, you need an MDCT of the buccal cavity. However, in tongue, the incidence of bone involvement is less than 10%. And it becomes an important imaging modality that you pick a modality which is more on in terms of soft tissue. So soft tissue is better seen on MR, it's multiplanar, and the tongue anatomy is better seen. You can predict the neurovascular bundle involvement better on MR. You can also pick the extrinsic muscle involvement. The deeper extension, the sublingual space is better, you can appreciate on the MR. So for tongue, the MR becomes the important modality. However, there are certain situations where you might need to use an adjunct, and we will see what are those situations in the following slides. So in head neck, why do we do imaging? For head neck cancers, we predominantly do not do imaging to diagnose. Diagnosis is only required if the patient has trismus, patient has limited mouth opening, and the clinician cannot evaluate the mouth oral cavity. If the oral cavity is adequately visible, the imaging is not done to diagnose, but it is done for accurate staging. By accurate staging, we mean that the T stage, whether the soft tissue is involved, whether there is perineural, whether the infratemporal fossa or the masticator spaces are involved, and the end staging. They both become important that we understand that predominantly the imaging is done for the staging, but not for diagnosis until unless there is a case which is having trismus. Imaging is the only modality which can assess the deeper extension. So let's say, take up the example of buccal cancer. By clinical examination, you cannot predict until unless there is gross mandibular nerve invasion. You cannot predict infratemporal fossa involvement by clinical examination alone. You need imaging for assessment of the infratemporal fossa. Similarly, laryngeal cartilages, they can only be assessed by imaging. The submucosal spread, the involvement of the paraglottic spaces, though can be appreciated on the clinical assessment like indirect laryngoscopy, but accurate diagnosis of these spaces involvement is only made on imaging. So imaging plays an important role in the T staging as well as in the N staging of the tumors. So there are various modalities ranging from computer tomography to MRI, ultrasonography, and PET-CT. We will see the pros and cons of each modality and which modality is suitable for which particular cancer we will see in the sub particular cancer type. In general, the three important things which one remember in the report is bone or cartilage involvement for T staging, perineural involvement because it is an important factor which guards the prognosis and can label a patient unresectable if there is extensive perineural disease. Nodal involvement, ipsilateral and contralateral. It's very important that you assess the disease whether it is crossing midline, because the moment the disease crosses midline, you should target looking up nodes on the contralateral side. So we have to be very very accurate in our assessment. The moment tongue disease crosses lingual septum, that means it is crossing the barrier and it is going on to the contralateral side, then your thought process should be that you have to look nodes on the contralateral side. So how do we image the neck? We actually divide the neck into base skull, that is the important foraminas at the base skull, then the orbit, and then the sinonasal cavity, the oral cavity. The hyoid bone divides the neck into supra and the infrahyoid neck. The suprahyoid neck would consist of the oropharyngeal mucosa and the nasopharyngeal mucosa. And the infrahyoid neck will constitute the pharynx and the larynx, which will continue down into the postcricoid region and continues down as cervical esophagus. So as I said, the optimum modality has to be taken into consideration. MDCT with puff cheek technique, that means you ask the patient to purse the lips and blow against the pursed lips. This technique is called as puff cheek technique, is used for buccal cancers. So why we need this puff cheek technique is because you want the mucosa to get separated from the alveolar mucosa. So you have the alveolar gingiva over here and you have the buccal mucosa. If you do not ask the patient to do puff cheek technique, the buccal mucosa will get approximated to the alveolar gingiva, and you may you may have suboptimal evaluation of the disease. So by doing this maneuver, you get an optimal visualization of the vestibule as well as the buccal mucosa and the gingivobuccal sulcus. So remember that any buccal cancer disease, one must perform a puff cheek technique. For the tongue, as I said, that the incidence of involvement of the bone in tongue is very little, it's under 10%. The modality of choice for the tongue malignancies remain MRI. For the base tongue and the tonsillar malignancy, if you have a disease which is extending into the retromolar trigone, then you can supplement the patient with MRI, with CT scan plain images to understand whether the RNT is eroded or not, or whether there is erosion of the pterygoid plates or not. Moving further, the other important sites are the base skull and the nasopharynx. So base skull and nasopharynx, the modality of choice is contrast enhanced MRI. I usually supplement a CT scan in high resolution HRCT window for base skull cases. The idea is that you should not miss any subtle erosion in the base skull, where you may not get a marrow change on the MRI, and you need a CT scan images to understand whether the foraminas or the base skull erosions or the clival erosions or the sphenoid body erosions are present. So the modality of choice for nasopharynx remains MRI. However, you supplement MRI with HRCT cuts of the temporal bone, including the base skull. For larynx, there is a debate going on, and there are two schools of thoughts. Personally, I advocate using MDCT of the larynx. Reason being, we are well accustomed for reading the MDCT. It is a very quick modality. You do not get deglutition artifacts. It is very patient comfort is there, and MR is used as a problem solving tool where the cartilage is not ossified, and we will see those examples as well. So remember that the base skull, contrast enhanced MRI, supplement with HRCT cuts of the temporal bone and the neural foraminas for assessment of any erosions. For larynx and hypopharynx, MDCT remains the modality of choice. However, you supplement MRI in cases where the cartilages are not ossified. That means the cartilages are seen as white line of the cartilage. So let's see what you see on a puff cheek technique. When you do a puff cheek technique, you get the buccal mucosa, which is represented by the white arrow. Usually the buccal mucosa is 2 to 3 millimeter in thickness, and one should look for asymmetry of the buccal mucosa in very early T1 diseases. So what you have to look for is a gutka chewing person or a person who is chewing pan for a very long time, he may have submucosal fibrosis. So when you ask the patient to do puff cheek technique, the involved site will not insufflate as compared to the contralateral site. So that's an indirect sign to pick up oral submucosal fibrosis. If you see heterogeneity, or you see focal irregularity, or you see focal ulceration or focal asymmetric thickening, that means this oral submucosal fibrosis is undergoing a malignant transformation. So again, I'll stress that the puff cheek technique must be done in an oral cavity tumor assessment. Moving on to the from the buccal mucosa, you have the upper alveolus and the lower alveolus, and at the junction you get the gingivobuccal sulcus. So here is the gingivobuccal sulcus. There is gingivolingual sulcus, which is on the interior side. This is the tongue proper. The tongue forms a sulcus with the interior alveolar margin, and that is called as the gingivolingual sulcus. It is very important to understand that the dentition has to be kept in mind. A dentulous socket gives a free way for the tumor to go into the mandible through the socket. Otherwise, if the patient has teeth which are present, it will act as a barrier for the disease to erode the mandible, and it strongly holds the mandible. However, in a patient, in an elderly male or a patient who has dental infections where there is loss of tooth, the socket is open. Hello?
Yeah, your screen sharing has turned off.
1 second, I'll do it again. Can you see now?
Yeah, it's visible now.
Is my flow okay? Are you able to hear?
Okay,
Hello?
fine.
Yeah, okay.
Hello.
Thank you. Yeah.
It's fine.
Yeah. So I was saying, like, we have to understand, sorry, I got stuck. Where were we? For the tongue proper, you need MR, as I said, and I was talking about the dentless and edentulous socket. So I've seen over years that we overlook the dentition of the patient, and dentition of the patient is very important to be reported in the scan, especially at the level of the tumor. You must report whether the socket is edentulous or dentulous at the level of the tumor, because if the socket is edentulous, there is atrophy of the mandible at that level, and the mandible is already smaller in size. It has got the bones have a kind of atrophied in that area, so it indirectly acts an a free way for the tumor to enter the mandible. So a CT interpretation, how it should be done. I request all the people who are reporting head neck, they should do a workstation based reporting. It's very important that you do 3D reconstruction and oblique reformats. Oblique reformats are very important for inferior alveolar canal assessment and subtle bony changes which cannot be otherwise seen on sagittal, coronal or axial sections. So oblique reformats are very important, and the reporting must be done on a workstation, not on the films. So the three windows which we usually come across in head neck is the soft tissue window. This is a typical soft tissue window where you are seeing the subcutaneous fat, the bones are very dense, the marrow is not appreciated. Then there is something called as the bone window, which we usually see used to assess the vertebral column or the pelvic bones or the ribs. But this bone window does not hold any significance in head neck imaging. We need something called as bone algorithm images, and now you can appreciate the difference between the two. So this is bone window images and these are bone algorithm images. You can see the matrix of the bones very well. You can see the marrow, the inner and the outer cortex very well. You can appreciate even the intricate structures such as the malleus and incus. So this is what you get by the bone algorithm images. Remember that the bone algorithm images are to be processed at the time of acquisition. You cannot get bone algorithm images after you have finalized your imaging, because it's difficult. You need to have the raw data to get the bone algorithm images. So it must be a preset thing in your department that you have bone algorithm images fixed within any head neck imaging being done. So bone algorithm images will help in the skull base. It will help in the mandibular assessment. It will help in the cartilage assessment in larynx also. It is required in every part of the head neck imaging. As I said, oblique reformats, and this is a classical example. The oblique reformats will help you assess the inferior alveolar canal, disease extending from the inferior, from the mandible into the inferior alveolar canal, or erosion which is benign versus a malignant erosion. So this is a erosion which is focal corticated. It is there is focal thinning of the cortex over here. Some sclerosis is also seen and appears to be a benign erosion. However, if you compare this particular erosion, there is no sclerosis, there is a permeative pattern, and this is true tumor infiltration. And this is a very classical example of an edentulous socket, where you see that the sclerosis has come all along the socket and you are not seeing the tooth within the socket. And this is classical focal depression when you have a loss of tooth. Let's begin with the imaging anatomy from the cranial to caudal. So the first section, which we start from the head neck imaging, is the orbital sections, and usually the head neck CT scan must run from the base skull up to the sternoclavicular joint, because you want to see the supraclavicular nodes, and you want to see the level 5B nodes also. So you must include up to the sternoclavicular joint so that you don't miss any nodes, especially if you have thyroid malignancies, if you are doing imaging for thyroid malignancies, or you having a lower post-cricoid region disease, then you might miss a skip lesion in the cervical esophagus, or you might miss superior mediastinal nodes. So it is very important that one must include up to the sternoclavicular joint. So the first cut which we see is the cut where you see the superior orbital fissures. The superior orbital fissures, they tend to open laterally, and they form a perpendicular 90-degree angle with the optic canal. So the next cut which you see is the medial opening, which is the opening of the optic nerve. It runs medially as compared to the superior orbital fissure, which is opening laterally. This is the optic canal over here. So the optic canal runs medially, and the superior orbital fissures runs laterally. They form a perpendicular angle, that 90-degree angle at that cross section. And it is important to remember that superior orbital fissures open laterally. As we go further down, you have the cavernous sinuses, which are very important for assessment whether the disease is extending along the mandibular nerve into the pterygopalatine fossa and reaching up to the cavernous sinus. Disease reaching up to the cavernous sinus is an unresectable disease. However, patient needs palliation and the radiotherapy planning has to be done. So cavernous sinus assessment becomes important. In dicey cases where you are not very sure, I recommend that you supplement contrast MRI with 2D Fiesta and 3D Fiesta sequences, so that you do accurate assessment of the cavernous sinus. Because if the patient is undergoing radiotherapy and the field of view is not adequately included, you may miss on in treating the cavernous sinus disease, which may lead to later recurrence and inadequate treatment. At the same level, when you see the cavernous sinus, you have the internal auditory canal. Internal auditory canal is leading into the semicircular canals, and then you have the ice cream cone appearance, which we saw in the bone algorithm images. As we go little down, you have the inferior orbital fissures, which again are like inferior to the optic canal. And remember that they are again medially placed as compared to the laterally placed superior orbital fissures. As we go a little down, the most important section of the base skull comes, where you have the important foraminas. You have the foramen lacerum, which holds the internal carotid artery. You have the foramen ovale anteriorly, and the foramen spinosum, and these are the three important foramens which you have in the base skull. So foramen ovale over here, and foramen lacerum, which holds the internal carotid artery. The moment you let's have a look on the perineural nerves of the base skull. So you have the facial nerve, you have the glossopharyngeal nerve, you have the mandibular nerve, and the trigeminal nerve. So the trigeminal nerve gives the three divisions: the ophthalmic, maxillary, and mandibular. One must remember the three nerves and how they are moving in and out. So the mandibular nerve goes from the foramen ovale. It gives the anterior trunk, an inferior alveolar nerve, and a lingual nerve. But remember, when the lingual nerve is given, it forms a connection with the chorda tympani, and which is a branch of facial nerve. So you may have disease of the in perineural spread along the lingual, but it may spread along the chorda tympani and may involve the facial nerve also. This is called as retrograde perineural spread. The second important division is the maxillary division, which comes out from the foramen rotundum. The maxillary division forms a pterygopalatine ganglion at the pterygopalatine fossa. This pterygopalatine ganglion further gives nerves, which are the inferior orbital nerve, or the nerve of the inferior orbital fissure, that is a zygomatic nerve. Sphenopalatine, through the sphenopalatine foramen, it gives nasopalatine nerve. Through the pharyngeal canal, it gives pharyngeal nerve. Through the greater palatine canal, it gives greater palatine nerve, and through the lesser palatine canal, it gives lesser palatine nerve. So the ophthalmic division gives the frontal nerve, the nasal nerve, and the lacrimal nerve. These are the three branches of the ophthalmic nerve. Again, we have to remember that the Vedian nerve, which runs through the Vedian canal close to the pterygopalatine fossa holds the median nerve, which forms connection between the glossopharyngeal nerve and the maxillary division of the trigeminal. So there is connection of the lingual nerve with the seventh nerve through the chorda tympani, and there is connection of the ninth nerve with the fifth nerve through the median nerve, that is the nerve of the median canal. On a skull radiograph, you can like a vague subjective assessment can be done. So you have the Meckel's cave where you have the trigeminal ganglion where the division takes place. You have the V1, that's the ophthalmic, which is giving 3 branches, the nasal, frontal and lacrimal. You have the V2, that's the maxillary, which is giving branches again, and then the V3, which is the mandibular nerve, which runs along the inferior alveolar canal into the inferior alveolar nerve and the lingual nerve. So what happens in a perineural spread? Perineural spread can be seen as foraminal widening or erosion or enhancement at the level of the foramina. But widening is the most important factor on CT. Asymmetry between the two foramens is an indirect sign of foraminal widening. Asymmetry more than 1 millimeter is considered significant. Some of the foramens may be congenitally enlarged, or the asymmetry is actually a physiological or anatomical variant rather than actual disease. Second important point is the enhancement. Always and always remember that every nerve has a artery which is running adjacent to it. The tumor becomes hypervascular. The enhancement can be pseudo enhancement because of the capillary drainage into the through the foramen. So we must remember that the thickening of the nerve with enhancement is a diagnostic sign. Alone enhancement is it can be a false positive sign which has to be confirmed on MRI. So if you see just mere enhancement without thickening or without foraminal widening, it must be confirmed on MRI using Fiesta and the 3D FSPGR sequences. You have loss of fat from the foramen, which is again an indirect sign of perineal spread. You have the thickened nerve and enhancing nerves. Enhancement along the pterygopalatine fossa or the Meckel's cave or cavernous sinus are again direct signs of perineal spread. You have indirect signs which are seen at a later date. So once the nerve gets denervated, the muscle undergoes atrophy. So if you see that the muscles of mastication on the involved side would be atrophic, there will be fatty replacement, there will be prolonged T2 signal, and there will be spurious contrast enhancement because the bulk has gone down. However, the vascularity remains the same, so the enhancement appears more. So you see feathery enhancement along the fibers of the muscle, which are indirect sign of denervation change. So now coming to these important foraminas, and as I said that the bone algorithm images are the important images where you have to assess this these foraminas. The foramen, the most important foramen, that is the foramen ovale, where the mandibular division would run through. The foramen rotundum over here, where the maxillary division will run through, and this thin line over here is the Vedian canal. The Vedian canal is the medially placed one. It runs, the Vedian nerve runs through this. The Vedian nerve is the connection between the pterygopalatine ganglion and the ninth nerve. And you have the foramen lacerum through which the internal carotid artery runs. Then you must compare your foramen ovales on the coronal sections, because the foraminal widening is best appreciated on coronal sections. So asymmetry of the two foraminas should be compared on the coronal sections, and these are the two foramen ovales. Then you have the foramen the foramen rotundum and foramen and the Vedian canal over here. So the round one over here, which is laterally placed, is the foramen rotundum. The medially placed one is the Vedian canal. So foramen rotundum will have the maxillary division, and Vedian canal will have the Vedian nerve. Why these foramens are important? Because they are leading to the main pathway, that is the pterygopalatine fossa. So this is the roof of the pterygopalatine fossa. Any disease once reaches the pterygopalatine fossa becomes unresectable, especially when the neural compartment is involved. So this is the area of the pterygopalatine fossa. I'm showing you the roof of the pterygopalatine fossa. We'll see in the subsequent sections the body and the floor of the pterygopalatine fossa. So what is pterygopalatine fossa? Pterygopalatine fossa is a pyramidal structure which is an inverted pyramid. Just invert a pyramid. The apex of the pyramid is ending on the maxilla. It ends on a maxilla with greater and lesser palatine nerves. So you have the floor of the pyramid, which is actually the apex. It's inverted pyramid. So the apex is lying on the maxilla, where you have the two important canals that are the greater palatine and the lesser palatine canals, which host the lesser palatine and the greater palatine nerve. These nerves can have perineural through the hard palate disease. They can have disease spread through the maxillary sinus malignancy. So this is one pathway for spread of perineural spread along the maxillary division into the pterygopalatine fossa. Coming anteriorly, you have the maxillary sinus wall, anterior maxillary sinus wall, and you have the inferior orbital fissure. Along the inferior orbital fissure, you have the inferior orbital nerve, which is again a route of spread along the perineural spread. So if you have maxillary sinus disease, malignancy, and you have inferior orbital fissure involvement, you can have perineural along the inferior orbital nerve, which should be looked upon anteriorly. Then you have the roof, which opens at the greater wing of the sphenoid and the inferior orbital fissure, and the greater, all the important foraminas which are either posterior or along the roof. So the predominant number of foramens are posteriorly placed. On the top, on the top, close the roof, you have the foramen rotundum, the Vedian canal, and the foramen ovale posteriorly. Then you have the lateral ones. There is the pterygomaxillary fissure. The pterygomaxillary fissure is in close proximity with the mandibular nerve, so you can have disease spread along the infratemporal fossa into the maxillary division or the mandibular division. So this is the lateral wall of the pterygopalatine fossa. And the contents, as I said, the pterygopalatine ganglion is the content. The descending palatine artery is a content. So descending palatine artery, if it is hypertrophied or it has neovascularization, it can give spurious enhancement, and you might label it as pterygopalatine fossa involvement. One has to be very critical into assessment of the pterygopalatine fossa. You have the maxillary division of the fifth nerve, and you have the Vedian nerve and the Vedian artery. So as I said, it was an inverted pyramid. To understand what are the important structures, once again, you have the greater and the lesser palatine nerves at the floor. You have posteriorly the foramen rotundum, the pterygoid canal, and the pharyngeal canal, and anteriorly the inferior orbital canal. So these are 5 important neural structures which meet at the pterygopalatine fossa. So let's see what happens. So you have this is the lateral border, which is the pterygomaxillary fissure. You have the medial one. This is the sphenopalatine foramen. This is the pterygopalatine fossa proper. And if you go little down, you will see that the fossa is opening again into the pterygomaxillary fissure, which is opening into the infratemporal fossa. So pterygopalatine fossa would open medially into the nasal cavity, laterally into the parotid space and the infratemporal fossa, inferiorly also into the low infratemporal fossa, and superiorly into the superior orbital fissure and the inferior orbital fissures. Let's look at the individual neural anatomy now. So the first and foremost, the largest canal which you will see is the greater palatine canal. The greater palatine nerves would run through the greater palatine canal, and this is the location of the pterygopalatine ganglion. So this is the root of the greater palatine nerve, which is opening into the hard palate. So the disease of the hard palate or the maxillary sinus will involve the greater palatine nerve. The lesser palatine nerves are little laterally placed. You are seeing the antrum of the maxillary sinus, and this is the thin ones which is laterally placed to the greater palatine is the lesser palatine foramen. And the lesser palatine nerves are multiple in number. You can have 2 or 3 foramens as well. On the axials, you can see that this is a pterygomaxillary fissure. This is the Vedian canal. Anteriorly, it is opening into the nasal cavity, and this is the root of the inferior orbital fissure over here. If you see the axial sections from base to craniocaudal, you see the pterygopalatine fossa. It is opening into the greater palatine and the lesser palatine. So the greater palatine is the larger one. The lesser palatine, shown over here by the yellow arrow, is the smaller foramen. So this is the coronal cut of the same. On the coronal cut, you can see the pterygopalatine fossa, which is opening into superior orbital fissure, inferior orbital fissure. You have the pterygopalatine fossa proper, and which is opening inferiorly into the greater and the lesser palatine nerves, medially into the nasal cavity, laterally into the infratemporal fossa. And this is one of the most superior cuts, where you have the foramen rotundum, which is opening over here, and the disease can spread along the spheno-occipital sutures into the jugular foramen also. So the disease has come from the infratemporal fossa, it goes into the pterygopalatine fossa, it is going through the foramen rotundum, it reaches the median or the foramen ovale, goes posteriorly into the spheno-occipital ridge, and can involve the jugular foramen. So you may have disease in the infratemporal fossa, which has spread along the pterygopalatine fossa, and the patient is presenting with glossopharyngeal nerve palsy or tongue deviation, but the tongue was otherwise not involved, and you see that there is atrophy of the tongue. Try to look for the jugular foramen and the pars nervosa and the pars vasculosa, whether there is perineural spread which is going up to the jugular foramen or not. So this is a classical example of a perineural spread, a thickened band-like structure which is seen extending from the mandible, from the mandibular foramen, reaching up to the foramen ovale, a thickened band structure. This is running between the two heads of the pterygoid. That's the lateral pterygoid. This is the medial pterygoid, a classical example of mandibular nerve perineural spread. So this is a diseased pterygopalatine fossa. You have the disease in the infratemporal fossa, which is reaching up to the pterygomaxillary fissure. You have the involvement of the pterygopalatine fossa. Erosions of the foramina is seen. The median canal is involved. It is extending posteriorly. The lacerum is eroded. You see the normal wall of the lacerum. The lacerum is eroded over here, and the disease is reaching up to the jugular foramen, and probably this patient would have glossopharyngeal nerve involvement as well. Now coming on to the important muscles of the head neck. The first and foremost, you need to understand the pterygoid plate and the pterygoid muscles. So there are two pterygoid plates and two pterygoid muscles, the medial and the lateral pterygoid. The lateral pterygoid is more horizontal, the medial pterygoid is more vertical. The lateral pterygoid inserts into the body of the mandible, and the medial pterygoid inserts into the angle of the mandible. The lateral pterygoid plate gives origin to the lateral pterygoid muscle. The inner border of the lateral pterygoid and the medial pterygoid plate gives origin to the medial pterygoid muscle, which will insert on the angle of the mandible. So you have these two muscles over here. The vertically placed muscle is the medial pterygoid muscle. The more horizontally placed muscle would be the lateral pterygoid muscle. This is the temporalis muscle, which is inserting like a fan. So you understand that the temporalis is something like a fan over here, and the fan, the stick of the fan, is going medially and inserting into the inner border of the mandible. So temporalis inserts into the medial side of the mandible. Then you have the other important muscles, which is the mylohyoid sling. That is the inverted U-shaped muscle, the sling, which forms a barrier between the floor of the mouth. Just 1 second. Just excuse me for a minute. Yeah, so you have the inverted mylohyoid over here, and you have the two bellies of the digastric. So it's very important to understand that the bellies of the digastric forms the floor of the mouth. It is outside the mylohyoid. The moment the floor of the mouth is involved, that means it's an advanced disease, and the patient might need NACT or may need advanced surgical resection. As we move forward, I forgot to tell you the masseter muscle over here. So the masseter muscle is the outer, along the outer border of the mandible, forms one of the important muscle of mastication, and it is the masseter muscle. Important spaces we must know before we jump onto the malignancies per se. The first and foremost space, which is the fat containing space, is the buccal space. The buccal space contains the parotid duct, and this is the parotid duct which is running. At times you may have occlusion because submucosal fibrosis can lead to occlusion of the parotid duct opening, which is an indirect sign of parotid duct involvement. So what you can do is, when you do ask the patient to do puff cheek technique, you see some air foci which is running into the parotid gland and along the parotid duct, which tells you that the parotid duct is functional. If it doesn't happen, it might be that it is involved by the submucosal fibrosis or the disease per se, the buccal disease per se. Posterior to the buccal space, you have the masticator space. The masticator space has the masseter muscle, the mandible, and the pterygoid muscles. So you have two muscles, that is the masseter muscle and the pterygoid muscles, and the mandible, which forms the masticator space. Posterior to the masticator space, you have the parotid space. The parotid space is a space which contains the parotid and the intraparotid nodes. Remember that presence of malignant intraparotid node is considered as a poor prognostic outcome. So if you have a buccal disease which has thrown intraparotid node, it is a poor outcome indicator. The parotid gland runs along the stylomandibular foramen. This is the styloid process and this is the mandible. The gland is actually having a superficial lobe and a deep lobe. This is a superficial lobe and this is a deep lobe. The retromandibular vein within the gland is a landmark for the facial nerve. The deep lobe extends through the stylomandibular foramen. So if you have the disease of the deep parotid gland, there will be widening of the stylomandibular foramen. So the styloid and the mandible will get widened because of the disease of the deep lobe of the parotid, which is an indirect sign for either deep lobe extension or epicenter of the disease at the deep lobe. Then you go more medially and you get the carotid space, which holds the carotid vessels. And if you see anteriorly, that's the pre-styloid parapharyngeal space, that is fat containing space, which hosts the parapharyngeal nodes. If you go medially, you have the pharyngeal mucosal space. The mucosa forms of the pharynx forms this pharyngeal mucosal space. And the bow tie appearance over here is the retropharyngeal space. The retropharyngeal space consists the longus colli muscle and the retropharyngeal nodes. So why the pharyngeal mucosal space is important? Pharyngeal mucosal space is the origin of the nasopharyngeal CA. And how to identify the pharyngeal mucosal space? You identify the torus tuberous and the enhancing mucosa over it is the pharyngeal mucosal space. This is a typical example of an nasopharyngeal CA, which is arising from the pharyngeal mucosal space, which is involving the parapharyngeal space fat as well. And the normal parapharyngeal space fat is seen over here, which is uninvolved. Again, as I said, like the pterygopalatine fossa, the parapharyngeal space is a gateway to multiple spaces. So it's very important to understand the parapharyngeal space. The parapharyngeal space is a fat containing area which has a roof but no floor. So it runs from the base skull, from the foramen ovale, and opens into an open space into the submandibular space. So it is a gateway for the disease to spread from the foramen ovale up to the submandibular space. So you can imagine this is like a railway line which is starting from the submandibular space up to the foramen ovale, and any disease can reach up to the base skull through this particular space because it is a fat containing space. The parapharyngeal space opens medially into the pharyngeal mucosal space, anteriorly into the masticator space, laterally into the parotid space, and posteriorly into the carotid sheath. So carotid sheath has to be kept in mind because you can have vagal nerve involvement because of the parapharyngeal space involvement, and that can be an indirect sign for patient with drooling or has a difficulty in swallowing. This is a typical example of lesions in the parapharyngeal space, and the orientation of the vessels are very important to understand whether the lesion is neural in origin or sympathetic in origin. Is it a carotid body tumor or it's a schwannoma? That becomes very important. So the location of the vessels becomes very important, and this is beyond the purview, but I just wanted to highlight that the carotid space sheet must be understood very well, the anterior structure, the posterior structures, and the structures within the carotid sheet, so that you can adequately diagnose the parapharyngeal space lesions. So the pharyngeal mucosal space versus the parapharyngeal space, the disease would start in the pharyngeal mucosal space, and the moment the disease involves the parapharyngeal space, that becomes a T2 disease. And this is an example. The pharyngeal mucosal space is involved over here. The parapharyngeal space fat is not involved. However, on the contralateral side, the parapharyngeal space is involved. That means the disease has become T2 now. Then you have the posterior spaces, that is the perivertebral space. The perivertebral space includes the prevertebral and the retropharyngeal spaces and the paraspinal spaces. Usually they are not so important, but I try to look for retropharyngeal nodes in all my cases so that I am not missing on any of the cases of nodal involvement. The next important structure, which is the infratemporal fossa, and I would like everyone to pay a lot of attention at this particular juncture because this is very important structure for assessment of head neck malignancies. The infratemporal fossa is different from the masticator space, and one has to understand what is the relation of infratemporal fossa and what is the masticator space. So infratemporal fossa is a surgeon space, masticator space is a radiologist space. Masticator space is a bounded space, it has boundaries. Infratemporal fossa does not have boundaries. So infratemporal fossa is shown over here by the red dotted line. It excludes the mandible and the masseter. What is included is the medial and the lateral pterygoid, the pterygoid plates, and the parapharyngeal space fat. The moment you include the masseter and the mandible, but exclude the parapharyngeal space fat, that becomes masticator space. So the difference between the two is masticator space has mandible and masseter, and infratemporal fossa does not have masseter and mandible, but it has parapharyngeal space fat. This is a line diagram again showing the medial and the lateral pterygoid, which is forming the part of the red colored area is forming the part of the masticators, the infratemporal fossa. But if you include the mandible and the masseter muscle, the yellow one is represented by the masticator space, and you have excluded the parapharyngeal space. So the parapharyngeal space is excluded from the masticator space. Why this infratemporal fossa is important? The infratemporal fossa is divided into low and high infratemporal fossa. Low infratemporal fossa is a fossa which is below the sigmoid notch. Any disease which is below the sigmoid notch is resectable disease. That means it has not reached pterygopalatine fossa. Any disease which has gone above the sigmoid notch, that is high infratemporal fossa disease, and the outcomes are very poor. This was a very small study in 45 patients by Liao et al., where they showed that the infratemporal fossa can be divided into two parts, the infra and the supra. Low and the high infratemporal fossa. The high infratemporal fossa involvement has poor outcomes. So as I said, we have to identify the low and the high ITF. How do you identify? On the axial sections, the moment you see the separation of the mandible into the coronoid and the condylar process, that means the sigmoid notch has started. That means your high infratemporal fossa has started. So this is the level of the low infratemporal fossa. This is the level of the high infratemporal fossa. You have the retroenteral fat, which is part of the high infratemporal fossa, but it is still resectable. So if the disease is extending into the retroenteral space in the high infratemporal fossa, it is considered as resectable, and this should not be labeled as unresectable disease. However, if the infratemporal fossa is involving the lateral pterygoid muscles, or it is involving the pterygopalatine fossa, that means it's an unresectable disease. The another important structure when we go a little bit down is the retromolar trigon. And the retromolar trigon is important structure because it's gateway to involvement of multiple spaces. Anteriorly, it communicates to the buccal mucosa. It can involve the mandible and maxilla, which is very adjacent to it. Medially, it can go to the base tongue and the floor of the mouth. And posterior-medially, it can reach up to the tonsil. And posteriorly, it can go into the masticator space. So you can imagine that one disease, which is in the retromolar trigon, can involve multiple spaces. That is the buccal space, the masticator space, the pharyngeal space, and the carotid space. The next anatomy we will look into is the tongue anatomy. The tongue is divided into two parts, anterior 2/3 and the posterior 1/3, which is clinically seen by the circumvallate papillae. However, on imaging, we can't appreciate the circumvallate papillae. So how do we divide the tongue? We draw a line which is starting from the soft palate, extending up to the hyoid bone, which divides the tongue into anterior 2/3 and the posterior 1/3. The reason of this division is the treatment of choice for the two diseases is different. The anterior 2/3 of the tongue is primarily treated by surgical management, and the posterior 1/3, that is the base of the tongue disease or the BOT disease, is primarily treated by the radiotherapy or chemoradiotherapy. So let's start looking at the tongue anatomy. This is the superficial cut of the tongue, where you have the intrinsic muscle which form a fern-shaped pattern. This is like a fern pattern with the lingual septum in between. The lingual septum has a bright line because of the fat within, and these are the intrinsic muscles. You have the medial pterygoid, which is close to the angle of the mandible. You have the masseter over here, the fat in the buccal space. You have the parotid duct over here, the buccal mucosa, and the parotid gland over here. So these are very simple structures. One must on day-to-day basis must practice these simple structures. As we go a little down, you see the muscles are becoming even now more prominent. The fern-shaped pattern is seen better now, and the lingual septum is also clearly visualized. The moment we go a little down, you start appreciating the extrinsic muscles. So the extrinsic muscles they are named by the origin or the insertion. So you have the genial tubercle over here. The genial tubercle is on the inner side of the mandible. It's a small structure. If you see, go to the anatomy class and pick the mandible and rub the hand onto the inner side of the mandible, you will see a small tubercle which gives origin to the geniohyoid muscle, which is an inverted V-shaped muscle. This inverted V muscle is the geniohyoid muscle. Lateral to it is the fat containing area, that is the sublingual space fat. However, when you go posteriorly, you have another V which is formed over here. The medial limb of the V is the hyoglossus muscle, and the lateral limb of the V is formed by the mylohyoid muscle. So again, I'll repeat, you have the inverted V-shaped geniohyoid muscle taking origin from the genial tubercle. You have the sublingual space fat over here, and then you have another V which is forming over here. The medial limb of the V is formed by the hyoglossus muscle, and the lateral limb is formed by the mylohyoid muscle. As we go a little further down, you appreciate the muscles even better. And if you go a little down, then you get the floor of the mouth and the digastric muscles. So these are the anterior belly of the digastric muscles, the submandibular glands, the hyoid bone, the pharyngeal constrictor muscles. So pharyngeal constrictor muscles are important if you are planning robotic surgery, because the involvement of the pharyngeal constrictor muscles is an contraindication for robotic surgery. So this is actual image where you can appreciate the submandibular glands, the anterior belly of the digastrics, the hyoid bone, and the pharyngeal constrictor muscle over here. The important structure which we must look into the sagittal sections, because sagittal section is one which tells you the involvement of the genioglossus muscle. The genioglossus muscle is a fan-shaped muscle. Again, it takes origin from the genial tubercle and inserts into the intrinsic muscle. So the fan starts from the inner border of the mandible and starts inserting into the intrinsic muscles. The intrinsic muscles being the transverse, vertical, and longitudinal muscles. You have the floor of the mouth, which is formed by the mylohyoid muscle, and superior to mylohyoid, you have the geniohyoid muscle. So geniohyoid muscle takes origin from the genial tubercle and inserts into the hyoid bone. On the coronal section, we try to look for the mylohyoid sling. The mylohyoid sling is very important as it forms the floor of the mouth, and disease beyond this is again advanced disease. The second important structure which you appreciate on the coronal image is the neurovascular bundle. The neurovascular bundle is seen over here. Basically, you do not see the nerves, but the nerves accompany the lingual artery, and the flow void within the lingual artery is appreciated on the coronal images when you want to assess the neurovascular bundle. There are normal enhancing structures in the oral cavities, the lingual tonsil and the palatine tonsil, which should not be mistaken for disease of the BOT. So lingual tonsil is at the level of the base tongue, and palatine tonsils are at the level of the tongue proper, which is at the level of the tonsils. So these normal enhancements should not be mistaken as disease. So let's come to each specific disease now. I'll start with the nasopharyngeal CA. So nasopharyngeal CA, imaging modality of choice, as I said, is MRI. For local extent, for marrow invasion and perineal spread, all three things are best seen on MRI. Problem solving tool is the HRCT cuts of the base skull for subtle bony erosions and foraminous involvement. Metastatic and nodal mapping should be done and must be done by PET-CCT. It's an adjunct. So in our center, we do MRI as well as PET-CCT, because you pick distant metastasis of the nasopharyngeal CA and pulmonary metastasis by using PET-CCT. Nodal assessment is also very good. Response assessment is also very good. So you need to have contrast enhanced MRI and PET-CCT. If you're doing PET-CCT, please do not do this normal CT, because you are anyways going to get the CT cuts through the PET-CCT. Treatment of choice, RT in early cases and concurrent chemoradiotherapy in advanced cases. And imaging helps into planning the RT field. So it's very important, the intricate structures which I showed you, the optic canal, the superiobital fissure, the inferiobital fissure, the cavernous sinus, all these are very important structures. Preservation of the optic nerve, preservation of the important nerves during the radiotherapy planning, preservation of the midbrain and the brainstem. All this must be kept in mind while helping your radiotherapy colleague in planning the radiotherapy fields. So coming on to the T1 disease, It arises from the pharyngeal mucosal space. So this is the pharyngeal mucosal space close to the sphenopalatine recess. So this is the sphenopalatine recess, and the foramen of the torus tuberous is actually occluded on this side. If you see that this is the torus tuberous, and there is occlusion of the torus tuberous, the torus tuberous occlusion will indirectly lead to mastoiditis. So try to look for signs of mastoiditis in nasopharyngeal CA. It will tell you the epicenter of the disease, it will tell you the extent of the disease, and it will tell you that the patient is presenting with sensorineural hearing loss, or hearing loss is present, and its conductive hearing loss is present, which is due to the obstruction of the eustachian tube because of the inflammation of or involvement of the torus tuberous, and the mastoid air cells are not getting aerated properly. As the disease progresses and involves the parapharyngeal space fat or the prevertebral muscles, that is the longus coli, that means the retropharyngeal muscles are also involved. This becomes a T2 disease. And the moment the disease involves the marrow or the clivus or the paranasal sinuses anteriorly, this becomes a T3 disease. So as I said, it becomes very important to pick early subtle erosions, which can be a T3 disease, which can only be appreciated on this bone algorithm images as seen over here. So there is subtle erosion of the sphenoid because of the malignancy, and it might be missed on the MR as well as on the routine bone window. And then you have advanced diseases where there is spread along the V3 or involvement of the cavernous sinus as seen over here. So the disease extending along the foramen ovale, reaching up to the cavernous sinus, and you can see on the axial the asymmetric enhancement of the cavernous sinus. This is a classical example of T4 disease. Apart from the T staging of the disease, one must look for the retropharyngeal nodes. The retropharyngeal nodes are laterally placed. They are usually necrotic and they are bilateral. Remember that the retropharyngeal node and the parapharyngeal nodes are the ones of the draining site, the sentinel draining site for nasopharyngeal CA. And then the next nodal stations comes are the level 2, level 3, and level 4. One must look for all the nodal stations because there is very high propensity of nasopharyngeal CA to throw nodal metastasis. Next important disease is the tongue carcinoma. The CA tongue, again, imaging modality of choice, as I said, because we want to see the soft tissue. Bone involvement is very little. MR remains the choice of modality. It tells you the extrinsic muscle involvement. It tells you the perineural invasion. It tells you the neurovascular bundle involvement. So the best modality is MRI. If you have subtle bony erosion, especially when you have a disease of the RMT, you can supplement with CT scan for picking up the erosion. However, there is no significant change because the number of cases, it's, as I said, like 10% of the cases of the tongue cancer will have mandibular invasion. Then you have metastatic and nodal mapping, which we usually prefer to do a CT thorax in our center, plain CT thorax, but some centers prefer to do PET-CT, especially in advanced cases. So what is an advanced case in CA tongue? When you have floor of the mouth involvement, or you have lower jugular nerve nodes involvement. So you are having level 4 nodal station involvement. These are indications to do a metastatic workup. And the metastatic workup should not be done with chest X-ray. Either it can be done with a plain CT thorax, or you can do a PET-CT. I recommend in resource constrained countries, CT thorax is adequate for assessment of the pulmonary metastasis. Treatment of choice, single modality versus multimodality treatment depending on the type of the disease, and imaging helps into the assessment of the disease extent and the choice of the therapy. So what all you would try to look for on a tongue cancer MRI? You will do the size assessment, the tumor thickness, the depth of invasion. You will do the extension of the disease across midline, because if the disease is crossing along midline, that means you will have contralateral nodal disease. Extension into the muscles of the tongue, which was a significant criteria in the AJCC 7, but has been eliminated in the AJCC 8 because the pathologists could not differentiate between the intrinsic and the extrinsic muscles. So the extrinsic muscle, which was T4A, has been removed from AJCC 8. It is very difficult for pathologists to tell you whether it is extrinsic muscle or intrinsic muscle, and the actual staging could not be done. So they have removed this particular criteria. Involvement of the adjacent structures, involvement of the mandible, involvement of the submandibular duct and the neurovascular bundle is best seen on MRI. So what are the key imaging features which you would try to mention and which will guard the treatment? You have extrinsic muscle invasion, which is high advanced disease, which used to be considered as T4A in the AJCC 7, but now is removed. Multimodality treatment is required. Spread across midline, as I said, if you have spread across midline, you may have contralateral nodal disease. The risk of contralateral nodal metastasis goes up to 12% in cases where there's cross midline crossing disease, and you need to plan the neck, contralateral neck also. Small volume disease, if it is involving the extrinsic muscles, which is again removed, as I said, some of the slides would be old, but it still is important to understand the bulk of the tumor would be removed. So if you have a small volume disease at the genial tubercle, the disease has started just at the tubercle itself, and all the origins are involved. That means it's a small volume disease, but it's an advanced disease. Neurovascular bundle involvement, if it is ipsilateral, you can have hemiglossectomy, but if both the neurovascular bundles are involved, you need a total glossectomy, and it's a morbid surgery. If the disease extends into the posterior vallicula or the preepiglottic space or the hyoid bone, it is a relative contraindication and chemoradiation can be given. Posterior spread into the masticated space is very advanced disease. You do not see tongue disease extending into the masticated space and infratemporal fossa. They are very advanced disease. Usually palliative arte is the modality of choice. And if there is bone erosion, depending on the type of the bone erosion, mid third or the lateral mandibulectomy can be done. If there is no bone erosion, if just abutment, you must calculate the paramandibular soft tissue as well as the disease and the residual mandibular height to plan the mandibular resection. So let's concentrate on the tumor thickness and the depth of invasion. So the two terminologies are entirely different. Tumor thickness, which used to be used before in the before AJCC 8, is now replaced by depth of invasion, and the two things are different. I'll show you in the subsequent slide. So the lateral to medial dimension of the tumor is tumor thickness. However, the disease extending underneath the mucosa into the submucosa is the depth of invasion. So you remove the exophytic component from the tumor thickness and you get depth of invasion. In a endophytic tumor, whatever is seen is actually tumor thickness as well as depth of invasion. In exophytic tumors, you have to exclude the exophytic component to calculate depth of invasion. Tumor thickness more than 4 millimeter, the incidence of neck metastasis is quite high, and elective neck dissection is recommended, especially if the tumor is more than 4 millimeter in thick. So you draw a perpendicular line on a contrast enhanced coronal MRI from the cranio to the caudal margin of the tumor, and you take the maximum medial and the lateral dimension that forms a tumor thickness. Now, if you see, this was the exophytic component of the tumor, and this becomes the depth of invasion. So the depth of invasion is the tumor exophytic component minus the tumor thickness. So looking at the examples now, you may have a very small volume disease which can be resected with wide local excision. However, this is another example of small volume disease, but it is arising at the genial tubercle and it needs major resection because the origin of the muscles are involved. You have indirect signs of extensive disease such as submandibular duct involvement and submandibular gland inflammation. So you see the ipsilateral gland being inflamed, large, enhancing, and the duct is prominent. That means the submandibular space is involved, the submandibular duct is involved, and it is upstaging the disease to a higher grade disease. You may have disease limited to the ipsilateral compartment, reaching up to midline and crossing midline. So the moment you have crossing midline disease, as seen in this particular example, you have contralateral nodes which are appearing necrotic. You must look for contralateral nodal disease. You have ipsilateral neurovascular bundle involvement, which is best seen on and evaluated on the on the coronal images. As I said, you cannot appreciate the nerve, but you can appreciate the vasculature. So the lingual artery flow void is read on the images, and any disease abutting the lingual artery is an indirect sign for neurovascular bundle involvement. You may have a bilateral neurovascular bundle involvement where you will need total glossectomy. The floor of the mouth involvement, as I said, you have to appreciate the mylohyoid sling. The moment the mylohyoid sling is involved, the disease is extending into the submandibular space, and you can see a necrotic node also at the level 1B. This is an example of a floor of the mouth involvement. We must keep in mind that we differentiate between the base of the tongue disease vis-a-vis a disease in the anterior tongue reaching up to the base tongue. So this is a classical example of base tongue disease. You can see the disease is only limited to the base tongue. It is involving the posterior 1/3, and the anterior part of the tongue is absolutely normal. However, this is an example of anterior 2/3 of the disease, which is extending into base tongue, into the tonsillar fossa, into the anterior tonsillar pillar, and lower up to the epiglottis. So this is anterior disease involving the base tongue. So this is a large volume disease, very dismal prognosis. This is a small volume base tongue disease, primarily treated by chemoradiotherapy. Then you have a very extensive involvement of the all the spaces. You may have masticator space involvement and other spaces involvement. This is very poor prognosis and gross extension of the disease seen in this particular example. Important for mandibular invasion. So mandible, as I said, it's seen only in 10% of the cases. The first example I'm showing over here is the focal abutment of the mandible. However, the cortex is absolutely normal. In such cases, if in doubt, you can do a plain CT of the mandible to see if there is any focal erosion. This is an inner cortex involvement with marrow involvement. However, the outer cortex is absolutely normal. This is through and through mandibular invasion with pathological fracture, and this is extensive disease. Again, poor prognosis with a large necrotic node, and multiple bilateral necrotic nodes are also seen. Coming on to the next important disease, which is the carcinoma of the gingivobuccal sulcus, lip, and the retomolar trigon. Imaging modality of choice is CECT with puff cheek technique, which is one-stop shop for soft tissue, bones, and lymph nodes. You have MR, which is a problem-solving tool when you are suspecting involvement of the pterygopalatine fossa, or you have dental amalgams, which are limiting the assessment of the mandibular cortex involvement. Metastatic nodal mapping, again, I would suggest like metastatic workup can be done by plain CT thorax. If you want, you can supplement by CECT, PET CECT, but choice is yours. PET CECT would become one-stop shop in advanced cases. Treatment of choice is surgery versus multimodality, depending on the size of the tumor and extent of the disease. And imaging plays an important role in assessment of the infratemporal fossa and the pterygopalatine fossa, which is only seen on imaging. So this is a small volume disease, only exophatic tumor, which is limited to the buccal mucosa, no extension at all. Early T2 disease. This is involvement of the maxillary sinus. This is an example of the mandible, which is eroded, and the inferior alveolar canal is also involved, and the skin is involved in this particular case. The skin involvement or the bone involvement becomes T4 disease. Again, this is an example of the upper maxillary involvement. The bone is completely eroded, the infratemporal fossa is involved, and the disease is extending into the lateral wall of the pterygopalatine fossa, that is the pterygomaxillary fissure, and reaching up to the pterygopalatine fossa proper. So this is unresectable disease. This particular disease must be confirmed that the disease is not extending into the foramen ovale or cavernous sinuses. How to assess the perineural? The most important perineural in buccal is along the inferior alveolar canal and the mandibular nerve, and which is at the mandibular canal. So this is the normal mandibular canal with fat. The fat is replaced by soft tissue. On the post contrast images, you can see that there is enhancement along the nerve, and you can see the thick band with asymmetric widening of the foramen. So this particular foramen ovale is widened. There is enhancement which is tracking along the foramen up to the foramen ovale, and on the bone windows you can see that the foramen is quite widened. This is an definitive sign of perineural involvement along the mandibular up to the foramen ovale. You have indirect signs of perineural spread. As shown over here, there is fatty replacement with T2 hyperintensity and post-contrast extensive enhancement. The post-contrast extensive enhancement is due to the loss of the muscle bulk, but the hypervascularization because of the vasodilatation. The next important disease is the hard palate disease. And in hard palate, I like to use both CT and MRI. So when I'm evaluating hard palate disease, I need my CT scan to assess greater palatine foramen and lesser palatine foramen. I need MRI to see perineural along the nerve, and assessment of the bone is best done on the CT. Assessment of the mucosa is best done on the MRI. So in a case of hard palate, both the modalities must be performed in a hard palate case. Now we move on to the spaces of the infrahyoid neck and the infrahyoid malignancy. The most important space, which is the laryngotracheal column. This is the visceral space which has the cartilages and the lumen per se. Then you have the anterior cervical space, which is a fat containing space which is bounded medially by the visceral space and laterally by the sternocleidomastoid muscle. Posteriorly, you have the carotid space where there is IJV and the carotid artery, the CCA. If you go posteriorly to that, there's retropharyngeal space, which is gateway for the disease to any kind of infection or disease process from the skull base up to the mediastinum. And then posteriorly, you have the superficial space and the prevertebral spaces. So let's now discuss the anatomy of the larynx and hypopharynx. So we have the larynx, which is divided into three parts. The glottis, which is bounded by the true cords. So the true cords are at the level of the glottis, and this forms the part of the glottic purse proper. The superior to this is the false cords and the ventricle, and this is the part of the supraglottis. The inferior to the glottis is the subglottis. Sorry. We'll go by axial cuts now. So the first and the foremost thing which you see is the mandible. After the mandible, the inverted U-shaped bone which will come is the hyoid bone. The hyoid bone gives attachment to the epiglottis. This is the fixed edge of the epiglottis, and this is the free edge of the epiglottis. The fixed edge of the epiglottis has pre-epiglottic space fat, which is over here. So the pre-epiglottic space fat is between the hyoid bone and the fixed edge of the epiglottis. As you go further down, you see the opening of the piriform sinuses, which we'll see in the subsequent cuts. But one important structure which one has to really look into is the pre-epiglottic space fat, because pre-epiglottic space fat in hypopharyngeal malignancies have a prognostic is a prognostic marker. The involvement of more than 50% of the pre-epiglottic space fat is a poor outcome indicator as compared to the less than 50% pre-epiglottic space fat. So epiglottis takes origin from the hyoepiglottic ligament. This is the hyoepiglottic ligament, which is this is a thyroepiglottic ligament which is attached to the thyroid cartilage, and this is the hyoepiglottic ligament which is between the hyoid and the epiglottis. The space bounded between the two is the fat containing space, which is the pre-epiglottic space, and it is seen over here. The yellow space is the pre-epiglottic space. So this is the hyoid, the thyroid cartilage, the hyoepiglottic ligament, and the epiglottis proper, and the fat containing area over here is the pre-epiglottic space. This is best appreciated on the sagittal cuts. Then next important structure comes as the aryepiglottic fold, the medial and the lateral ridges. You have the piriform sinuses. The piriform sinuses go lower, and then the apex of the piriform sinus is seen. The moment you start seeing piriform sinuses, the hyoid starts disappearing, and then there is another bony structure or an ossified structure which starts appearing is the thyroid cartilage. So under 40 years of age, there are chances that the cartilage is not ossified, and you are dealing with a non-ossified or a white line of the cartilage. So this is an example of non-ossified white line of the cartilage. You can appreciate that it's not ossified. It's appearing like a white line, and this is partly ossified, and it's completely ossified cartilage. So one must remember the cartilages are, the ossification usually takes place after 40 years. The second important thing which I would like you to focus is the lumen aperture. The lumen is triangular at the level of false cords. The lumen becomes more oval at the level of the true cords. So the false cords over here are fat containing structures. The moment you see the vocalis muscle, which is taking origin from the cricoarytenoid joint, this is the arytenoid, this is the cricoid. The cricoid is over here. This is the arytenoid. This is the cricoarytenoid joint. The cricoarytenoid joint is giving origin to the vocalis muscle. It is inserting anteriorly into the anterior commissure. The anterior commissure is the part where the muscle inserts and the pericardium is deficient. This becomes a gateway of the disease to spread very rapidly if there is anterior commissure disease. So remember, small volume anterior commissure disease can involve the cartilage early because the pericardium is deficient, and this is a space called as Broyles ligament, where the vocalis muscle inserts. As you go down, the lumen becomes more rounded, and that means you've reached the subglottic part. The subglottic extension of the disease is very important. Anterior and posterior subglottic extension has implication on the type of the laryngectomy which is planned. You have carcinoma of the larynx and hypopharynx. The imaging modality of choice, as I said, CECT because of the speed of acquisition. MRI can be used for problem solving tool where the cartilage is not ossified. You are in dilemma for the paraglottic space involvement assessment. And metastatic and nodal mapping can be done by PET CECT. Again, as I said, like I'm more towards plain CT thorax, but depending on the case to case basis, you can choose PET CECT as also. Cartilages can only be assessed on imaging. So let's see what all key imaging features change the modality management. So you have pre-epiglottic space invasion, you have paraglottic space invasion, or the post-cricoid region invasion. The patient is a T3 case, it needs a multimodality treatment. Erosion of the inner cortex, thyroid lamina, multimodality treatment with radical surgery. If you have destruction of the cartilage or exolaryngeal spread, total laryngectomy. If you have thyroid cartilage, ALA encasement but no destruction, you can give trial induction chemotherapy, reduce the volume of the disease, assess the cartilage again. If the cartilage is not involved, you can preserve the larynx if it's a functional larynx. If you have extralaryngeal spread of the disease, which is involving the carotid artery or the prevertebral fascia, it's an undissectable disease. So let's see the example. This is a very small volume disease restricted to the piriform sinus. It's an hypopharyngeal CA. And this is involving the apex and pre-epiglottic space is involved. The pre-epiglottic space involvement is best appreciated on the sagittal images over here. This is a T3 disease, which is involving the inner cortex. And this is a T4A disease, which is involving the carotids and the prevertebrals involved. This is a T4B disease. Again, the dilemma as CT versus MRI. So this is a classical example of a white line of the cartilage. A tumor is seen over here. There is focal enhancement which is reaching up to the cartilage, and I am in doubt whether the paraglottic space is involved or not. And if you do MRI, you can see that the paraglottic space is involved, but the cartilage is preserved. So this is what MR gives you in patients which are at dilemma. Either the cartilage is not ossified or you are in dilemma that the paraglottic space is involved or not. Another important thing which I said in my anatomy slides, that the anterior commissure disease are notorious diseases. The small volume disease can have extension and can involve the cartilage at a very early date. So because the pericondium is deficient because of the vocalis muscle involvement, insertion. So remember that the re-imaging of the anterior commissure disease must be done at 4 weeks interval. The next is the nodal staging. Clinically positive node to confirm. So there are two kinds of imaging which can be done for nodal staging. You have a positive neck where the clinician has palpated the nodes and they are there, present there. That the role of imaging is to do the how much is the nodal burden and whether the nodes are resectable or not. What is the angle of contact with the IJV? Is the IJV thrombus? Is the carotid involved? These are important criteria when you are dealing with a clinically positive neck. If you have a clinically negative neck, that means you are trying to look for occult metastasis, and which is very difficult to pick on a single modality. Multimodalities are used for picking up the occult metastasis. Coming on to the nodal stations. So the level 2 is the draining site for the tongue malignancies. The most common site, sentinel site for the tongue, tongue cancer. You have the level 1B and the 1A nodes. The 1A nodes are the submental nodes over here between the submental region. The red over here is the 1B node, and the posterior are the 2A nodes. As you go more posteriorly, you get underneath the sternocleidomastoid, you have the 2B nodes. And the moment you see hyoid bone, which is, and the bifurcation of the carotids, that means you have reached the level 3 node. So the bifurcation of the carotid is a landmark for the level 3. And the moment you see the cricoid cartilage, below that becomes the level 4 node. So level 4 starts below the cricoid cartilage. And don't forget your level 5 nodes, which are along the posterior border of the sternocleidomastoid. So clinically negative neck, as I said, it's very difficult to pick occult metastasis. The sensitivity of all the modalities is under 70%. And specificity is maximum with CT. However, the meta-analysis for PET-CT is still pending. Ultrasound-guided FNA accuracy is quite low. It is 48% in clinically negative neck. And no single imaging modality can replace surgical staging in clinically negative neck. So all the patients who have head neck malignancy must undergo elective neck dissection if the tumor thickness is more than 4 millimeter. That means by and large, every patient would have elective neck dissection, and that saves the life of the patient. In early stage node negative oral squamous cancers, elective neck dissection resulted in higher survival rates and disease-free survivals than the therapeutic neck dissection, which is the N0 trial by Tata Memorial Hospital by Professor Anil D'Cruz. And the possible alternatives to elective neck dissection can be sentinel node biopsy with which has a negative predictive value of 96%. In positive, clinically positive neck, you have extent and the number of the nodes, the number of stations which are involved, presence of necrosis and extranodal spread, because extranodal spread would make the disease N3 and poor outcomes. So which has to be seen on imaging. So perinodal standing, involvement of the muscles, involvement of the platysma, perinodal fat, central necrosis, these are indirect signs for extranodal spread. And relationship with ICA and CC are very important, especially with the ICA, because it might be that you need to resect the ICA and then you need to do a balloon occlusion test, and the contracted circulation has to be evaluated. So this is an example of a circumferential nodal mass which is involving the ICA, and the circumference is actually, the common carotid is involved more than 270 degree, and it's an unresectable disease. So points to remember: imaging checklist must have the epicenter of the tumor in 3 dimensions, the spread patterns, and the nodal status. The findings that has clinical impact in head neck CA is the bone or the cartilage involvement, because the surgical management would completely change if there is bone or cartilage involvement, and perineal spread would have implication on the outcomes as well as the recurrences. So with that, I would like to conclude that accurate staging is essential for optimal management of carcinomas of the head, neck, and the upper digestive tract. Imaging plays an important role in the staging, depicting infiltration of the hidden structures, deeper extensions which are usually not visualized by clinical or endoscopic evaluation, and communicating the radiological stage effectively needs adherence to a checklist of positive and negative findings. If you need the checklist and the synoptic reporting formats, I can send it across to Bishwajit, and Bishwajit can circulate to the society. Thank you very much.